at the end of the day, the data is clear. These patients who get motion-preserving surgeries heal faster and feel better for longer.
Welcome back to the Spine Pod. We are in LA.
Cannot complain about being able to sit down in LA in the middle of summer.
No, we hopped off a plane at LAX. We're here in West Hills. We just had an awesome conversation.
We did. So we were very fortunate to be able to sit down with Dr. Jared Ament here at the Neurosurgery Spine Group in West Hills in Los Angeles, California. And what an incredible practice they're building out here.
Really cool. Holistic care. You know, a man focused on all the things we love. Mission-driven, motion preservation, holistic care. I mean, what a good conversation to have for this podcast.
He is blending a lot of the aspects that are pushing spine care forward right now. Yep. He talks a lot about health economics and the research that he's doing. He's highly focused on motion preservation and how that pertains on a long scale to fusion. And then the mission work that he does and Dr. Vocation do as well is just a testament to the type of people that they are, to go over there and provide care and technologies and the options that patients wouldn't have otherwise.
Agreed. And, you know, he used the word honesty multiple times throughout our conversation. And I think that's a good definition of the conversation that we had and his approach to care, which is so important. A lot of just honest, frank conversation. It's what we need to be talking about as an industry and with patients. So I'm really excited to share this one.
And they're also deeply involved in the clinical trials here too.
Yes.
So they are working on getting the newest and the greatest technologies out to patients and providing that care and doing it in a holistic sense to not just the patients here in LA, but across the globe. And it is absolutely spectacular. And what a great episode to sit down with him.
It's a great one. So we hope you enjoy this one with Dr. Jared Ament.
Dr. Jared Ament, thank you so much for sitting down with us today.
Pleasure. Thanks for having me.
Absolutely. We're so excited. I mean, we couldn't get any better weather out here either. This is as good as it gets out here in West Hills.
We didn't pick you because we wanted to go to LA.
I get it.
You know?
We pay taxes for the weather.
Yeah, exactly.
That's
right.
probably why you have patients flying to see you as well.
Well, you know, we're super excited. There's a lot of topics that we want to get in here too today, but I want to start with talking a little bit about you. So you're the co-director of the Spine Neurosurgery program here at Neurosurgery Spine Group. You also run the research. You also founded Neuronomics, so your own company looking at cost effectiveness, things of that nature. You're on the board at the Institute for Neuro Innovation, which your partner, Dr. Vocation, started. And you also do work with Solidarity Bridge and doing some overseas and mission work and providing some of that care to,
awesome,
underserved areas. And if that isn't enough, you're a dad of 3 little girls. So you're a girl dad as well, but did I miss anything else or is that a good start?
I feel incredibly violated. You know a lot about me.
Yeah, your social security number will be next.
Wonderful.
You know?
Wonderful.
So we know you're a big motion preservation guy, and that's a lot of the topics that we want to talk about today, but we kind of want to bring it back to the start and what brought you here? Why are we sitting in this room and what brought you to medicine?
Well, thank you. That was a very nice introduction. I mean, honestly, I can think back to maybe when I was a teenager. I was young, 12, 13 years old. I remember people ask me, why did you do neurosurgery? Medicine, I don't really remember the thought process. But neurosurgery, I can probably trace back to preteen or early teenage years. My grandparents, I was born and raised in Toronto, Canada. My grandparents were, I guess, babysitting. My parents were away. And I have this distinct memory from that time period where they were angry at me because at 3:00 in the morning, my bedroom light was still on. And they came to figure out what was going on. I mean, I don't know how much trouble 12 or maybe these days, I don't know what a 12 or 13-year-old can get into, but I was putting together a model of the human brain and cervical spine. And I guess they decided not to interrupt me because it was an educational 3 a.m. event. I don't recall the impetus for doing it or why I wanted to, but I remember being fascinated by it. And I think ever since that period in my life, I was fascinated by neurophysiology, how the brain via the spinal cord controls the body. The trajectory towards medicine, not sure. I mean, I was 15, 16 and did through school volunteer work overseas in Central and South America, not directly medical, but kind of healthcare related, hygiene related projects. I always wanted to give back and help and expose myself to that, experience, but also give part of myself to that experience. And then from then onwards, very early on, I continued doing that type of work. Even in medical school, I was my first year off between years. I remember the summer, I was in Ecuador doing mobile surgeries in the back of a truck that was outfitted as a surgical suite to go from town to town to town, village to village. We didn't do very much at that stage, but it was certainly an incredible experience. So I don't know if it was just wanting to give back, wanting to help, understanding and loving the science, being fascinated by what we didn't understand. There's certainly kind of a gravitas about neurosurgery. It's like, you can do a heart transplant, but we certainly can't do a brain transplant. So there's something about being fascinated, but also humbled by the fact that we don't have all the answers. And there's this very vast world of research and entrepreneurial efforts and innovation going on in this space, I think more than almost any other. It's maybe where it all started, something like that.
It's fascinating when you look at that, because I think physicians in general, right, are drawn towards this. I want to help people, right? And I think you do that in your everyday practice. I'm not sure if you can find a better life journey than being a doctor, because you give back every day, right? You don't have to find something outside of that realm.
Yeah, I think teachers give back every day.
That's
too.
true. That's true. In terms of, your impact on individuals, being able to work with them every day, I think that interplay between medicine and then doing these mission trips, that's two different, I'm curious where you got that side of it, of the giving back, wanting to go to these underserved areas. Is that a faith aspect for you? Is that something you grew up with in your family? Because that you're busy as it is, right? So taking that extra time to go overseas and do those sort of things, it's not exactly glamorous all the time, is the best way to put it.
I don't know. I don't know if it's just part of my DNA. I mean, there's obviously some environmental exposure that has made me compelled. I mean, even during medical school, after that Ecuador trip, I went back and I lived in Ethiopia for several months and went back to Ethiopia 9 times. But I was a Harvard fellow, so Harvard has all these resources. So part of that, was where neuronomics came from, was doing international work, as a Harvard, researcher. So I don't know if it was a combination of interest and opportunity or opportunity and interest. I do think as I get older, entitlements bother me more and more. And we are at a very, very difficult time, I think, in our history as a species. Because in the first world, these societal kind of based entitlements there's a sense of we just want more. We just get more. COVID, politics, the divisiveness, people feel very entitled. And I think something about doing this mission type work, it's not faith-based for me at all. I mean, most of the mission work I do is often with Catholic or Christian organizations, and I'm Jewish. It doesn't matter. For me, it doesn't matter at all.
Yeah.
There is no entitlement when you go to these places. These self-entitled kind of experiences are gone. You can absolutely fail as a surgeon and a doctor, and the family comes to you with gratitude for trying. Here, you fail and you're slapped with 22 lawsuits, right? I mean, it's just a very different thing. So maybe it's nice to get to feel that, to get a sense that people truly appreciate what we're trying to do. Because frankly, look, there are always bad apples. Doctors sometimes do need to be sued. Sometimes that has to happen. But that's a small fraction of a percent. The vast majority of doctors want to do good and want to help. And it's hard when that's not always appreciated. And it's not that we need the pat on the back. We don't even need the appreciation. I don't need the thank you. I just want people to feel grateful for the fact that we really do care and are trying. And I think that I get a lot of that feeling and experience overseas. I don't know. I mean, a big part of my upbringing was martial arts. It was my first job. When I was 16, I was teaching 3 and 4-year-olds, like in the dojo that I trained at. That was my first job. They gave me kinder karate classes to teach, of course, for the junior guy. But, and martial arts was a big part of my life. So maybe giving back in going overseas is a way to find a balance is my meditation today. I don't know. It's a great question. I haven't really pinpointed an answer, but I continue to do it. I do it yearly, sometimes more than once a year. And I took my wife with me once, and I plan to take at least my older kids as well. And part of that is just trying to be a good parent and showing them perspective that not everyone has it as good as they do. And I think that that's really important because life is not always peachy and perfect. And what car are you driving? And I think sometimes people just need help.
Well, I think it's, what I'm hearing you say a little bit too is like it creates this balance in your life where a lot of times in America, we can get so stuck in the like, what do I have? What do I need? And like abundance and forgetting to have that like just appreciation and gratitude for just the simple things in life, which I've been on a mission trip or two. And you're humbled by these people and how happy and grateful they are for the simplest things. And it helps remind you kind of like, what is my North Star and am I on it?
Yeah, people say, "Oh, you're doing it just for the photo op, or you want the appreciation to feel good about yourself." I'm like, we all want to feel good about ourselves. Don't kid yourself, right? That's not the point, though. We also want to feel appreciated for the work we're doing, but we also just want to do good work with no strings attached. Here, often, and don't get me wrong, the vast majority of my patients are incredibly appreciative and loving, and I have an amazing relationship. I go to lunch with some of my patients, right? We have amazing relationships. But a lot of times people come in that don't have a relationship with me yet, and we're trying to establish a relationship, but I get a list of, well, Google said this, 14 other doctors said this, why do you think that? And it's almost like sometimes you feel it's an interrogation, and it's just, is that the reason why we went into medicine? It's not. It's the landscape that we have to navigate. That's okay. But there is certainly a North Star component where you feel like, nothing's changed. I'm doing the same type of work here or there. I'm just trying to do good work. But there's certainly something that just gives me that balance when you do that and you feel good about yourself. And you're allowed to feel good about yourself. You want to feel good. Sometimes you feel awful because you couldn't save that person or do what you wanted to do because of resources, or simply because you just couldn't, and you still feel somewhat okay that you tried. I mean, it's hard. We call it, my partner, Dr. Vocation, and I call it the neurosurgery pits. When things don't go well, I don't think patients truly understand because they're going through their own thing, right? And their families are. But when doctors truly care, and like I'm going to say it again, and the vast majority do, if it doesn't go well, because surgery is not 100%, and it's as much an art as it is a science, it is hard to reconcile that as a surgeon, as a doctor, as a person.
Well, I think for you too, going into medicine, if you were looking for an easy specialty, neuro and spine are not the two that you can walk through, right? Yeah. And so it's a challenge from that perspective. But I will say, at 12 and 13 years old, you were doing very different things than what I was doing at 12 and 13 years old.
Fair enough.
That's fantastic. But
I wish my 12-year-old was doing what I was, but that's, no.
It's a whole other story.
Whole other story.
So I'm curious, like you had this kind of feeling for wanting to give back and do these things, and you did a really interesting medical school process, right? So the Medical School for International Health, which is a 3-in-1 program, and I believe 3 years in Israel and then 1 here. What in a very heavy push towards global health. What brought you to doing that versus doing a more standard program here in the US or anything else?
Yeah, I mean, I think just kind of my calling, what I've always been up to. I was interviewing all over the place. And when I was interviewing at Columbia in New York, this was an option to do this international global track. Israel is a place that I feel very strongly about. I've been many times. And so it was an opportunity to combine both loves, if you will. And their emphasis specifically was on global health, which we did. I mean, part of my schooling wasn't even in Israel or America, it was in Ethiopia. So it was just the best of both worlds, and it ended up working out great.
And then stepping in and you got your master's of public health as well at Harvard. Was that something that you saw was going to advance the other work that you were able to do, or what made you take that additional step? Because you still knew that residency was coming, fellowship was coming. It wasn't that there was a lack of school and education coming.
It probably was the schooling initially, the medical schooling kind of, there was a lot of discussion during medical school about alternative tracks. There was PhD tracks, there was MPH tracks. This school and a few others are a little bit like feeders to Hopkins, Columbia, I think North Carolina and Harvard, the public health tracks. So there was certainly, I'm not sure I would have even been exposed to it if it wasn't for that, but there were certainly discussions about it. And there is a specific program at Harvard where the MPH is designed for clinicians, for MDs. So there's a regular MPH program for masters, people want to do public health administrative work. And then there's it's called a clinical effectiveness tract you have to be a doctor and graduate. So there's a summer program, you do it. I loved it. And then if you like it, you can continue in part of the MPH program. And then while there, that's when I became kind of a clinical fellow for kind of international health and doing a lot of missions and work at the same time, which is where neuronomics came from.
Can you talk a little bit about neuronomics?
Sure.
I think it's a fascinating topic. So we actually just recently sat down with Dr. Ahilan Sivaganathan, and he does a lot of work on cost effectiveness and healthcare economics. And I saw that neuronomics was along the same path. That's why I thought, motion preservation and having this interplay between motion preservation and cost effectiveness is super interesting. I'd love to dive into that on what drove that for you.
What drove it initially?
Yeah, what drove it initially?
I was a poor student. I mean, married, and my wife still tells me to this day, she remembers me sitting. So neuronomics has obviously evolved. But part of this, the tract at the School of Public Health at Harvard was clinical effectiveness, and then there was electives, and one of the electives was healthcare economics. So I took one course initially with this very famous, I don't even know if he's still alive, his name is Milt Weinstein, arguably the grandfather of healthcare economics, at least in this country, wrote the book. And it was fascinating. I've always been strong in math growing up, and then the idea of looking at resources and sustainability when looking at healthcare and technology and advancement was fascinating. And so I just kept doing more and more of those electives. And then with some of the clinical research and fellowship stuff that I was doing at Harvard, they talked to me about going overseas on some of their trips and helping them with research, because part of the MPH program was outcomes research and statistics, and specifically that I was interested in the healthcare part and the economics part. So I said, sure. So I started Ethiopia, Sudan, multiple times, lots of places in Africa. And what I realized afterwards was that there is a sustainability issue domestically also. So internationally, it's just pure finances, right? they cannot afford it. This is new technology. It doesn't make sense because they can't afford the old technology. The system isn't in place to support the people. How do we figure out a loophole? In the States, it's very different. Multiple layers of bureaucracy. Everything is more expensive. And does a new advance justify, paying for it from a systems perspective? And, the thing that always catches people is cancer therapy, right? Cancer is life-saving therapy. So the question is, do you spend $250,000 or $500,000 or $1 million on 3 months or 6 months or a year of this new drug if it only improves your quality of life or improves your life sustainability or life duration for a couple months? Does that make sense? Some would argue, who are we to make that decision? Unfortunate truth is that if you say yes to everything, if you're a parent, you know this, right? If you say yes to everything, at some point the foundation crumbles. More money is spent on an individual during their end of life than their entire life when it comes to healthcare. I'm not saying that's right or wrong, it's simply a fact. And the other aspect that I think was critically important, which I learned from Milt Weinstein and others, and this is sometimes hard, this is a cultural thing. There are states of being that are worse than death from a quality of life perspective. So when you start measuring healthcare economics and healthcare expenditure, you can't just say, oh yes, this is a great idea and keep someone healthy. How do you define healthy? And how do you define quality of life? And so what I realized is that this is also a problem. It's a different perspective, but it is an also enormous problem domestically in the United States. And I realized I was going into my internship year, and we had a young child, and my wife was going back to school. And residents make $7 an hour and work 120 hours a week rather. And so I was like, well, I have this skill set. Let's start a business. So my wife fondly will tell me that she remembers seeing me in the corner, after a night on call. at my computer, my desk, doing all kinds of programming and doing this sort of research stuff to try and look at data and do data mining for companies or for universities or for departments. And we were doing pretty high level data mining to assess costs and quality of life for certain interventions. And that just became a business to, one, help us get through those years, and two, now it's another way to give back, because I support researchers and research assistants and PhD students and statisticians that do a lot of that for me now, and I guide them. I still am boots on the ground because I'm still going places and doing those sorts of things, but it's another way to give back, and it's another way to keep the research and the academic aspect of our practice going. So my partner has the I&I Institute of Neuroinnovation, and we've kind of, somewhat, we've definitely collaborated, but we've amalgamated a little bit in terms of how neuronomics and I&I work together. We're constantly doing research together back and forth, because we'd like to believe we're a private-demic type practice. We are private. We're not employed by a hospital, but we are actively doing research, a lot of it. We have multiple FDA clinical trials. We have other projects that are independent. We have a collaboration with my mentors, Todd Lamon and Pat Johnson, that we're working on, that we started. And it's another way of giving back, to the community, science community, as well as the public. People are savvy. They're savvy shoppers. They understand more and more, and they want better information. They deserve it.
I think that's so true. And it takes me back to something you said earlier when, you said patients sometimes now come in and they're like, well, here's my list of things, and I don't trust you right off the bat, which is difficult to, bring someone into. It's a stressful situation they're in, and be able to have those conversations. Yeah. I'm curious your thought on, for spine in general. I think in the US, there's a stigma around it because of fusion. Mm-hmm. You've spent a lot of your career and belief in motion preservation. I think that also very much fits into what we're learning about you today, of just the giving back, what is better for people. I'm going to go out and do the right thing. What led you to motion preservation, and how do you think those things are connected?
First and foremost, I have to give credit to mentorship. So, there are a few people that really did kind of allow me to kind of think beyond and not just fall in. I was never really falling in line. If you ask my residency program director, I never really fell into line, and some people chastised me for it, but others didn't. Ki Kim at UC Davis, a phenomenal spine surgeon, he really embraced my research and wanted me to think beyond. Neil Anand, Pat Johnson, and Todd Lamon really, allowed me to think beyond and pushed me to and embraced it. And then my partner, Amir Voksher, is the best partner that a guy could ask for. Most neurosurgeons don't get along with one another, whether it be ego, whether it be difference of opinions. I don't know. You ask 5 spine surgeons that, how to solve one problem, you get 6 answers, right? So, but Amir Voksher also, out of the box thinking on his own accord, never had a partner, and really embraced what I was, thinking about and offering and talking about. And so much so that we have this beautiful sort of synergistic relationship. Our wives even like each other and often tell us to go away and spend more time together. But mentorship helped. The right mentorship helped. And then I also, you have to think back to just being commonsensical about how you approach things. If you get and I'm not an orthopedic doctor, but if you get a hip transplant, do they put in a cement block? No, they give you a moving joint so the hip still works. If you get a knee replaced, do they put in a block? No, they give you a knee. So the concept of fusion, which we were all trained to do, it makes sense. If, God forbid, is a high-speed trauma and the spine is like this and unstable and you could be paralyzed, you have to fixate something that's unstable. Instability requires stability. Not because the spine cares, spinal cord cares. What's in between it, right? What's in the middle of it. And so it made sense. And so, and I saw what some of the mentors were looking at and doing, and I read the research. And look, the research is everything is imperfect. The big research, a lot of it's industry sponsored. And that's okay. You just have to realize that it is. But this isn't a new concept, right? It's been decades of physicians and doctors and scientists all over the world, in Europe, looking at ways to preserve motion in the spine. And I think it's really indisputable at this point that it's a superior option for patients, for the right patients, compared to fusion. Now, there are many of us that are pushing the envelope again and looking at ways to really use motion preservation in ways that it was never tested. So are we experimenting? No, but we're conducting what we believe to be safe, regulated trials, looking at options. And that is kind of the frontier type thinking that we're talking about today, is what's the next step? What's the next level? And there's always going to be concerns. There's always going to be people say, whoa, it wasn't tested in that. Okay, but there's a lot of things that weren't tested initially that we use off-label. Gabapentin was not tested for neuropathic pain. It was given for seizures. No one prescribes it for seizures anymore. They always prescribe it for neuropathic pain. It wasn't tested. It's still off-label by the FDA, how it's used by the majority. So I think when you start looking out of the box, thinking about the next frontier in spine surgery and how to make patients feel better, faster, you still need safety to be at the forefront of that discussion and that thinking. And that's why you need a group of responsible people who are less into the ego. To never say none. Every doctor and surgeon has ego, but you need a little bit of confidence, so you don't want that doctor. But you need them to collaborate. Like, I will collaborate with my mentors, and my mentors will collaborate with me. And that is the type of relationship, and my partner for sure, that who has 20 years on me, right? That's the type of relationship that, in my mind, will do the best science and best medicine for our patients.
And this is the reason that we're sitting down and having this conversation, right? A lot of this gap is around education, because there's still information out there that motion preservation is untested and we're not sure. That's not true, right? We have 7-year data, we have 10-year data, we have very long-term data on a lot of these. And I think the work that you're doing as well is, and you talk about this on Instagram, you talk about it on LinkedIn, is we will continue to monitor these things, right? But as long as they're giving good patient outcomes, why would we not restore natural motion?
Yeah.
There's a quote from you that you said, and it was, we have to stop the madness that fusion is the answer. It's not the answer. Fusion is the backup, right? And it's always going to have a place, right? Like you said, there's going to be trauma, there's going to be tumor, there's going to be these cases where fusion is going to be needed for stability for the safety of the patient. That's going to be the option. But in these other cases, can motion preservation start to prevent some of those things down the road, right? So if we get these degenerative cases, if we don't wait 10 years or 12 years to treat them, or start getting some of this ASD, can we kind of work in earlier in the care period?
And if you want to look at the minutia, I mean, the question is, can we really prevent some of these natural degenerative processes from happening? And the answer is, we really don't know. We think we can, and we're just not perfect at it. So if we prevent it happening by 3 years or 5 years or 10 years, we still think it's better than it happening now, or happening at an accelerated rate. It's almost like the red wine. Every year, Harvard comes out with not every year, 5 years. Harvard comes out with a study that says red wine's good for you. 5 years later, red wine's bad for you. It's the same thing. Fish oil's no good. No one knows, right? So there's certain things that are hard to discern and know for sure. But because there was a paper that came out, adjacent segment disease maybe not as, preventable as we thought. But then there's 40 other papers that say it is, right? So at the end of the day, the data is clear. These patients who get motion preserving surgeries heal faster and feel better for longer. I feel anecdotally in my practice, but I have looked at the data ad nauseum, that the adjacent segment disease is significantly less than fusion. It's not zero. And I keep telling patients this. Remember something. If we didn't touch you at all, and we let your diseased disc segment and lumbar, both, just kind of do its thing, you're going to get adjacent segment disease, because that disc segment is not working normally. It's not physiologic. So it happens in your normal body. On your own, it's certainly going to happen no matter what we do for an intervention. We're just trying to slow things down. It's like the anti-aging for the spine.
What should patients be coming in when they're asking for these procedures, right? And I want to know, what should they be looking for? Because the problem is, if you don't go to someone that does these regularly, that's a component, right? They're only going to offer what's in their tool belt. So
it's a very important point, actually.
So how do you find the people that are offering these products? Because if not, you're going to get the option that, which is probably the safer option as well. When you're looking at patient care, you operate with what you know best and what you can operate with best. How do you find the guys that are offering this, and what questions should you be asking?
Yeah, so that's actually a very fair point. And it's a little bit of a difficult point, because Todd Lamon and I talk about this often, that it really isn't, it's not that hard to fuse, right? So if you're trained well, and most of us are, most of the training is pretty, and there's always a bad apple. Everyone talks about Dr. Death and going off the rails. First time ever something like that has been that crazy. But the majority of people are very well trained. And to make, especially the cervical, but even the lumbar spine, a one level fusion doesn't have to be perfect, right? As long as it fuses, the person's safe and often will feel better, at least initially, somewhat. Motion preservation has become so nuanced that unless you're picking this just picture perfect patient, which I always argue if it's that picture perfect, the patient probably doesn't need surgery, right? But unless it's this picture perfect patient, you can throw in any disc, probably will do okay. What we have learned, and there's a group of us that kind of meet every year, about 30 or 40 of us, and talk about it from all over the world. Every disc is different. And this is my belief, and I have posted about this. When I say stop the madness, not only should you stop the madness about fusion, but it's obviously very easy for the community as a whole to say, okay, we're going to give you an artificial disc if a patient wants that, if they go to someone random who's never done it before, or does one. And I always say this, it's not a one-size-fits-all model. Yes, we size and shape and do things in the operating room, but every disc is built a little bit differently. Some have different properties. Some have different compressibility. Some have different tensile strength. Some have different constraints. Some have different, we call it kind of centers of rotation where the movement is occurring. All of these factors matter because not everyone's spine is the same. Even if everyone's spine was the same, that how it's degenerating or how it's affecting you is different. So that has to be addressed differently, potentially. So my recommendation, and I don't want all the business, right? I want people to do well because the last thing I want is a revision case that was just that person is suffering and it becomes that much more complicated to help them, right? And so there's plenty of business to go around. So the goal and the recommendation from any of these types of things, podcasts and information out there, is that share information so everyone can do a better job for their patients. And the answer is become as well-versed as possible and as many options as possible. And that's what we do. So, at our practice, we'll use every FDA-approved disc and ones that are not FDA-approved through clinical trials that are FDA-sponsored. And it's just becoming more and more nuanced, but I think that's good. That's better. We're looking at the global curvature of the spine and the global motion. We're looking at a segmental level by level. I've put different discs from different manufacturers in the same patient at different levels because of how it will potentially work for that patient and what they're wanting to do.
We've seen positives and negatives when we talk about this. We were talking a little bit before we started about patient information in some of these forums where patients can get information. I think it's fantastic that there's this sharing of information. Hey, here's what my dad got. Hey, my doctor offered this new option. I think there's a negative side of that as well. And there is now a big difference in the different discs that could be used based on your specific context and your pathology, right? So a lot of times I've seen this on these forums where they say, I saw someone got a disc replacement and it didn't work. They had to get it revised. And so therefore it's untested, it's unsafe, and you shouldn't get one. Right. That's like driving down the highway in LA and seeing a broken down car and being like, you shouldn't buy a car because I saw a car broken down, right? It's amazing because I think there's good and bad to that, but the importance is finding someone that knows the nuances between those options, right?
Yeah, and it's hard, and I think it's getting better because more and more people are getting exposed and experienced, and all the national meetings we're talking about those things. So it's getting better, but it certainly is scary. Those forums are good. I think they're good for learning a little bit about what's available and what's out there and people's experiences without jumping to conclusions. Generalizations are never a good thing, right? And my one concern is, and I have spoken to many patients that have found me or heard of me through these forums or on these forums, I do worry about the culture around, I wouldn't say multiple opinions, but like multi, lots of multi. A second opinion, third opinion, fine. I absolutely think that is 150% appropriate, okay? But when you're on your 14th, 15th, 16th opinion, my concern is either who you're getting these opinions from or that you simply just don't trust the system and don't trust medicine or don't trust doctors. And that's okay. I can't force you to, but my biggest concern is the patient that is losing function, neurologic function, and is having a hard time figuring out what to do because of all of these multiple opinions, right? If you're we as a community, as a surgical community, are doing a bad job at educating, or patients are so apprehensive or distrustful of the community that they're causing themselves harm. That, to me, is something I was grateful for you guys reaching out for this, because any opportunity to educate and give some candid information is an opportunity to help a patient preserve their neurologic function and get out of pain. Pain is one thing. Pain, is not always easy to treat, but pain is, the body's way of telling you there's a problem. If we get to you during the pain stage, there's interventions, sometimes even non-surgical interventions. But my biggest concern is if we get past that point and a patient is having true neurologic dysfunction or neurologic injury, then the neurosurgeon in me, right, that loves neurophysiology, building models as a 12-year-old, is saying, this is a problem we need to help. And if we can't get that patient help because they're either not willing or not able or not trusting of the help that's being offered, then we've failed. Then as surgeons and as a scientific community, we have failed the patient.
I think that earlier you said it's either you don't trust the medical community or there's not enough education. I think it's both.
Sure.
Is what's happening, right? And then you have patients you get decision fatigue. Like if you're looking for
sure.
15, if you're talking to 15 different surgeons, you can't make up from down at that point. That's really difficult.
Anything in life.
Yeah.
If you have 15 options in front of you, no one's going to know what's up or down. I agree with you.
Yeah.
And I don't know how to, other than educating, I don't know how to help with that problem. It's honestly, to me, from what I'm seeing over the last few years, is getting worse.
Well, that's the problem with technology, right? It's a double-edged sword of you have more information, but you also have more information, And how do you decipher what is good information or quality information and not? It's misinformation. But I think what you said, and I just want to reiterate it because I think it's really important for patients, is that those forums can be a great place for initial baseline information of, is there more that I should know about? Am I being told all my options? Let me learn what they all could be, but then go to the expert and have the more in-depth conversation about what those are and how they work for you as an individual. Because I see those forums as well, the Facebook groups, and people try to diagnose each other in there or say, this is what I got, so this is what you need. But to your point with the discs, of every patient is different and just your degen could be different. So what your sister got or your cousin got, whatever, could be completely different than what you need. And that leads me to another question. How do you have those conversations with patients? Because I think sometimes they do come in and they say, I want this specific disc, or I saw this online. And maybe being like, well, that's not right for you. How do you communicate that with patients?
One word: honestly. I'm very honest. I will tell patients that I completely respect where they're coming from. I understand maybe why they're concerned. Some people have concerns versus one disc versus another, some anecdotal experience that their friend or relative or chat group member had. I will not put a disc into a patient that I think is inappropriate. And then I can tell them I'm sorry if they want to go somewhere else to a surgeon that's willing to, but I'm always willing to hear them out, but I will only do what I think is safe and appropriate. And I'm honest.
You talk about decision fatigue and the difficulty that we have with making a decision with the best information we have. And I see this a lot when you talk about pushing the bounds, right? You use a lot of stuff off label. And so, you have cervical hybrids, and you have 3 levels, and you have 4 levels, and you have things that are currently not being put. You did a 360 arthroplasty, right? The first one that you'd call like a total arthroplasty, you did a disc replacement and a TOPS. There is no one out there that's saying, we're reimbursing this, we should be doing this. But from your research, this might be a good alternative, right? It might be a good option. And we're getting there where, hopefully very soon we'll have a total joint replacement on the market, right? So we're working towards these things. I'm curious how you have those conversations with patients. If we waited for everything to have 10-year data, we're going to lose so many patients to getting procedures that would benefit them right now. And I'm curious how you do that in your own practice, then how you have those conversations with patients on actually implementing and taking that next step and saying, no, this is a good alternative. We can do this, right? We can do hybrid cases. We can do 4-level CDAs, topics like that.
The same answer, honestly. I'm very candid. We have some data. We don't have a lot. It makes sense. This is why we think it makes sense. I encourage you to get a second or third opinion. They certainly probably will not offer what we're offering, and that's okay. I also, no one wants to do another surgery, right? But at the same time, I always tell patients, fusion, at least multi-level fusion, should be a backup because it's not physiologic. It doesn't make sense. If, God forbid, what we're trying doesn't work, we can always revert back to what everyone calls the standard of care, which I think should be changed, frankly, but we always have that as an option. We're like, well, why wouldn't you use it as the first option if it's your backup option? Because it works. Sure, it works, but it's not ideal, right? Why is spine surgery and fusion surgery, become such a bad word? Because fusion begets fusion begets fusion. The amount of breakdown and stress and unnatural kinematics that is going on in a fusion is well documented and unparalleled in any other joint in the body. You're not fusing someone's knee or hip, so it doesn't make sense. And so, yes, it's a backup that is a fail-safe. I can get it to a point where it's safe. It works, but it's not ideal if you want to still be doing yoga and running and jogging and living life and being active. It's just not normal. So, I'm at the stage in my career now where I'm seeing the patients with 10, 15, 20-year-old fusions with complete breakdowns. And I said, that's what we're trying to avoid. We may not get it right. We may not be perfect the first time, but everything we're doing is sensible and has some data and some research behind it, even if it's not yet evolved and developed. There's no final answer yet. Certainly, this is a very important part of kind of my practice and my beliefs. I will never do to someone else what I wouldn't do to myself or my own family member. And so is it experimenting? It's off-label work under the auspices of research, but all of these devices that we're using have been approved, may just not approved it together. And we are trying to make things better for people like I would want, for my family. And it is an absolute, that is the paradigm. That is what we do. How everyone in our practice is like a family member. We really want that to be the feeling. I think most of them feel that way. We really do care, even when we're doing something kind of cutting edge and on the frontiers.
I'm not sure if there's another surgical specialty that is like spine in that realm, where if you have a relative or your mom or your dad, or you hear about somebody that says, absolutely stay away from spine surgery at all costs. And we've got that because of, the way we've provided care for a long, long time. But the problem is we still have some of that belief, even though there are newer options here, right? So you're a big driver of TOPS. TOPS just got approval. You've got a facet replacement that can provide motion. You do plenty of discs, right? Both anterior and lumbar. Now with Modus, we'll have a total joint replacement here, hopefully soon, that just completed clinical trials as well. But we're still kind of holding on to some of that old theory, that old information. And, it's curious. I think doing the work that you're doing and getting it out there, and this education and promotion is what helps us get over that curve a little bit, right?
It starts to. And I think it's education and it's science. It's evidence. I think research is important. We have to do things that are evidence-based to the best of our ability. And when it's not evidence-based, we look at anecdotal, we look at group experience, we get expert opinions, we get everyone together to try and make decisions together. When I first started doing the 360-degree arthroplasty, we're doing a little mini trial here, and we have some of my mentors involved as well. Yes, we were certainly the first in America. And I think it's something like that has been done, overseas with the TOPS. And then certainly there's been people overseas doing it with other devices with the same concept, front and back. There was a lot of noise. I'm sure there was some criticism, but to be honest, I had a lot of people, often my competitors, who were like, good for you. It's a great idea, right? And sometimes that just discussion is the right thing to do because, again, I don't need and want to do them all. I want people to get the right surgery the first time. If we have to rely on fusion as a backup, we rely on fusion as a backup. I just don't want it to be the first surgery for patients who don't need it.
When you talk about this idea too of, well, if fusion works, then why stop doing it? Well, the question is, what does work mean, right?
100%.
And I think one of my favorite, we talked with Dr. Ketchatarian, we talked about this idea of probability versus possibility in surgery, right? And these concept of, that you've talked about previously, quality of life versus the alternative, if you want to call working, is pain reduction. Sure, you'll get pain reduction early, but this all ties into this cost effectiveness work that you're talking about. If working on a 2-year scale is our time frame, then sure, absolutely, let's do it. But now we're looking at 5 years, 10 years, 15 years down the road, right? And not only what are the implications to you and your body and getting another surgery, but what are the implications to society from an economic standpoint and your practice and for payers and for patients? It all comes together, right? But it is such a complex topic when
You're good. You're good. You segued right into it. I was about to say quality of life when I was talking about healthcare economics, because you're right. I think it's a physiologic necessity to maintain motion whenever we can. And we have to think long-term, because you mentioned, okay, we're not talking 2 years, we're talking 5, 10, 15 years. But I'm thinking one step beyond that. It's not even years. It's active years, quality years, right? So if you get a fusion surgery, a multi-level fusion surgery, and you just want to kind of sit there, okay, whatever, you're fine. But I want my patients, and most of my patients want active years. It's not just quality of life, it's high-functioning quality of life. You know, I had an amazing picture. It was such a beautiful video. A patient who was older gentleman, a little bit overweight, and he's retired, and all he wanted to do was play golf again. And at 8 weeks after surgery for the tops, for the artificial facet, he sends me a video of him swinging the golf club, playing tops with just smiles. That's all he wanted. You know, could he have done it with the fusion? Maybe. But we know for a fact, like Tiger Woods, after he had his multi-level lumbar fusion, his golf game was never the same. And there are many reports. Now, and this is why these chat groups are difficult. You're always going to have the patient that got a T10 to pelvis that did great, right? And just the data is clear. The majority of patients, fusions are not physiologic. You do not have high functioning quality of life for long, even if it buys you relief for 2 years, 5 years, or 10 years. It's what happens next. You know, a discerning audience would say, okay, but what about artificial discs at 10, 15, or 20 years? Because the revision rates are going to go up as well. Sure, the revision rates will go up, but they're going to be, from what we can tell, less than fusions. And it's very early data, but the 10-year data in Europe tops. It was like 1/3 the revision rate compared to fusion. It's a small sample, but it nonetheless is important to look at and understand. We have people with pro discs, and I'm not supporting pro disc one way or the other. I think you use the right disc for the right patient, but we have some of the oldest data for pro disc, for lumbar and cervical. There are patients in Europe with over 20 years, you know, of a version of the pro disc walking around. I mean, so there is data. There's even older discs, and you know, some have failed, some have worked, but there are patients, you can always pick the one off, right? And what I think it requires, and this is funny you mentioned Dr. Kachatarian, because we've been collaborating to work on this global registry idea to help collect this information, is that we need to do a better job collecting the plethora of data that's out there by the surgeons that are doing this to really understand what's happening at 5, 10, 15, and 20 years. Because there may always be the surgeon that will present the failures and complications. I think that's great to do. But at these conferences and national meetings, most people are presenting their successes. And so we need to be a discerning provider of care so that our discerning audience is getting the right information. And that's part of the effort. It's just more and more data collection, doing what we think is right, doing what we think is safe, and getting as much information so that the long-term data can reflect what we're feeling.
Well, not only that, it's what are we measuring? Because to your point, you know, you're saying, well, you could have a revision of a disc in 10 or 15 years too. But going back to, but what was your quality of life over those 10 or 15 years versus the fusion over 10 or 15 years? So let's measure those qualifiers as well. Like those often aren't what we are measuring.
Absolutely.
And so often then fusion can look better than it maybe actually is because we're looking at the wrong data points.
Very true. But you also, you know, at 15 years, if you do a disc revision, why do you have to convert it to a fusion? You may be able to revise it to another disc or a new disc or something that's out there. I mean, I would like to, you know, I hate everyone who says, oh, should I go to this and holistic? I'm a big believer in conservative management, do injections, do acupuncture. I love all of that. Meditation. We have a brain spa in our practice where we let our patients meditate. We have a nerve supplement that we're releasing that helps with healing. I believe in all of it. But if you're having neurologic injury or neurologic, you know, impending danger, I always would like to kick the can down the road as much as possible when it comes to fusion and say, let's preserve motion for as long as possible. Because if I preserve motion in 10 years or 20 years or 15 years and we have to do something else then, okay. Right? I mean, people need their hips possibly redone in 20 or 30 years. Everyone's different. I know patients that have had it in 10 years or 15 years. I hate to bring it up. It's not the same urgency, but Breast implants, they get revised every 10 years, I think. So for me, I will kick the can down the road 10, 15, 20 years if I can preserve motion every step of the way.
And preserve that quality of life. And one of the things that I think is most fascinating, because of things have gotten more stringent to get things to market, right? We watch the data much closer. And like you said, we have so much data now that looks at fusion versus motion preservation options. If we examined things this tightly when we were looking at knees and hips, we wouldn't have total joint replacements for knees and hips, right? People forget that it was so long ago that there was disaster cases, right? And now they're almost, I won't say perfect, but 95+% success rate, right? Knees and hips, you can knock them out. They're fantastic. People know they're great surgeries.
They trust them.
Right, exactly. But in spine, we look at this as so hesitant. We only have 10 years of data. That is so much more than we had when we started these other total joints. And I think that's something to keep in mind as well.
I think it's a great perspective. I mean, it's a really good point. Why is it that going in for a total knee or a total hip, for some reason, doesn't perturb patients nearly as much?
I hear people are like, I got a new hip. I'm excited. I'm out, like.
I mean, I have had a few patients bring me t-shirts saying I just had my spine surgery or something, and they were like very happy about it. But I it's interesting. I don't know why the PR campaign is different for the two. I mean, sure, you're working around the spinal cord and nerves. There are nerves around the knees and the hips, by the way, that can get damaged during surgery. I don't know. It's somewhere, somehow, I think patients have become distrusting. We have failed in the way we educate, and we're trying to do better.
Well, I think our timing too, right? Spine is just behind. Spine is behind. And so, like Brady said, there's kind of a bit more hips and knees kind of got to figure it out before we had the technology and the way to communicate with each other like we do now. And spine is like under a microscope while we're working on pushing the standard forward.
I wonder if we're really behind or if we've just had early failures that made everyone skeptical. Because there's truly, I mean, let's be honest, we have to be honest with ourselves. I think the only way to push research forward is honesty, right? And I think if you look back, I mean, there were ball-bearing joints stuck in spines in the 60s and 70s. I mean, there certainly people have tried to preserve motion for many decades. And I think some of the early failures have made people legitimately skeptical. Maybe it's more nuanced and more complicated than, I don't know anything about a hip and a knee, but I'd like to believe it's more complicated, but maybe I'm wrong. But it is certainly, I do think we're licking our wounds a little bit, and I think we have to do better, which is why I'm not against the red tape. Some of it is a little bit nutty, like the bureaucracy has created a barrier to innovation, and that's a problem. But I would never say that we should get rid of the red tape and sacrifice safety. So it's a balance. And I think we just have to do better. And I think, a lot of the motion preserving options that are out there now are really better. I mean, they really are offering a variety of options for patients and their problems. Is it perfect? No. But, either is our own disc that we were given, because clearly, we're outliving the discs, right? I wish it was as simple, and it's not. And I'm not trying to, in any way, simplify the matter. But, it's your shock absorber in your car gets destroyed. You go in, you get a shock replacement, and you're off and driving. It's not that simple. But what is simple is the analogy of saying if you have a shock absorber that's not working, if you replace it with a non-functioning shock absorber or a non-moving shock, what's going to happen to the other three? They're going to wear and tear faster because because of compensatory mechanisms, because you don't have that balance and that symmetry. Spine's more complicated, but it certainly behaves similarly.
So we've talked about the focus a little bit on some of these outcome metrics and how we measure success, right? I think one of the things that you were very good at is treating the patient and not treating radiographs or treating imaging, right? I think we can get lost in trying to treat one or the other.
Treat the patient, not the picture, I always say.
Exactly right. And I'm curious what you think if we're going to see a transition towards looking at some more functional success metrics. We've been focused very heavily on pain reduction in a lot of scores, but we haven't looked at, some of these things of quality of life or looking at return to work. We're starting to see more look at return to work. Do you think we're measuring the right success metrics? And then where is that leaning towards? Do you think we'll start to see some more functional metrics outcomes as we see motion preservation and fusion options?
I certainly hope so. I mean, I've started, all of the healthcare economics work that I've done in the past has included things like return to work and quality of life. But a lot of our standard questionnaires and metrics have always been pain. quality of life, mostly in the economic space, but it does come up. You see now more people looking at like the SF-12s and 36s and other questionnaires, and there's a variety of them. We mentioned before, quality of life and functional quality of life and high-level functioning is really what we're striving for when we talk about motion preservation. So it's starting. I think it's getting there. But just to give you a very actual, real kind of example of our limitations, but what we're doing, we're about to submit an abstract and hopefully a publication looking at return to sport after artificial disc on and off-label constructs. And that is a expert opinion, 10 surgeons from around the country that we have done what's called a Delphi method, multiple rounds of questionnaires and surveys, getting opinions, mixing and matching, using the same patient population, but mixing and matching the order and blinding them, and then asking the same questions over and over again and seeing what the consensus is, and then getting consensus statements. It is incredible to me that this far along in the motion preservation space that we are relying on surveys and expert opinion to generate a consensus statement about when someone can go back to sports, because we don't have any other metrics. Is it good to have this paper out there? It is. There's a similar paper that was published by Dr. Vaccaro on ACDFs and after fusion, when you can return to sport, because that was the gold standard. Everyone got a fusion, but a lot of athletes were getting fusions and wanted to go back to their careers. It certainly needs to be done in the motion preservation space, because we have plenty of athletes that are enjoying their careers and functioning at very high levels. And so the fact that this, first of all, this consensus paper didn't exist was quite startling. So I'm glad that we can offer that, and it will be out soon. But I was also taken aback by, these are the only kind of statistical research methods that we had, and there was nothing better. So to answer your question, it's coming. We're still very limited in what's considered a validated tool to assess this.
It's interesting. I think a lot of this gets pushed forward through clinical trials and, how we manage these and how we set them up so we collect the right metrics on the front side, right? Because you can run through all these things, and if you don't collect the metrics, it doesn't matter.
It's too late.
Right?
It's too late.
And so to your point, so much of it is just so subjective right now. And how do we get these functional outcome metrics that are objective, that we can actually measure, right? Of no, not like I think they can, or that sounds like a good idea, but no, they're ready, right? Yeah. And having these functional metrics.
Well, that's the one limitation. Quality of life measurements are mostly subjective, and they've been validated tools, but they're nonetheless subjective. And part of my training was looking at subjective metrics because they are important. VAS on on a pain scale is subjective. But it's validated because it's important to kind of ascertain what someone's level of pain is pre, post certain levels of follow-up and compare that to other people. The problem is what we learned a long time ago is that it really is only that good at comparing that person's pain score to that person's pain score at different intervals in their care, because everyone's impression is subjective. It's different. It's varied. And then it gets even more complicated when you go to different cultures or different places, with different appreciation for pain and different understanding of pain, because how one culture responds to pain or feels pain or treats pain or manages pain is very different than another. So you can imagine that they're responding to those questionnaires differently.
It's interesting.
So we have these tools that are validated, but if you really look at it, at a granular level, they're probably really good for that patient and that patient only, along the entire spectrum of care, which is fine. But to make these grand statements about, this technology improved pain scores compared to this technology because we're generalizing them to a population, that's probably not as accurate as we need to be.
It's fascinating to see what clinical trials are starting to collect as well. So we're starting to see more wearables data.
Yeah.
And I think that's going to be fascinating, because when you look at two different cohorts, right, a motion preservation group versus a fusion cohort, you're not just looking at a pain reduction, right? But you're looking at, when is this person up and walking? How active can they get? Are we getting people that are getting 10,000 steps a day, 7 days after surgery versus 30 days after surgery? And again, it's probably an imperfect metric, but it'll be really interesting to collect some of these data points and see, functionally, how are people doing immediately after surgery in some of these cases?
It's better than what we have now, but it's imperfect. Because for one patient, 7,000 steps is probably good, and for another patient, 30,000 steps is probably required to truly test. What was success? What to measure success? I have a patient, and this is my N of 1. But I don't know, but it could be the only N of 1 probably in the world that she's about to do an ultra marathon, 100-mile run on an artificial disc, a lumbar artificial disc.
Really?
So that's happening this summer. She already completed her 50, and she came to me because she was an ultra marathon runner and couldn't run anymore. And we did a 1-level disc replacement, and she's about to do, I think, is the only ultra marathon runner with a lumbar artificial disc that I'm aware of, but I could be wrong. Certainly my only patient that can do 100 miles.
It's still impressive regardless. I mean, it's so impressive.
100 miles is impressive or sadistic or I don't know what. I mean, that's a lot. Yeah. Forget just a regular marathon. So, incredibly proud of her progress, and she's obviously very happy. But, I bring it up only not to brag. It's not, I don't think it has anything to do with me. It has everything to do with her. But, how do we measure her metric what's her metric of success?
Because I guarantee, what's her pain level?
Yeah, I guarantee you that if she could run a marathon, which all of us would probably be very happy if we could do that ourselves, she would be, this is unacceptable if that's all she could do. So what's her metric, right? So I know her metric. Her metric is 100 miles. So we're getting better, but we're not there yet.
Absolutely. Well, we talk about clinical trials in general. You guys focus on clinical trials very heavily here at your practice. You're engaged in multiple clinical trials right now, right? So you're with the Synergy disc. You're looked at Big Era. You're looking at M6. You obviously were a big part of the TOPS trial, and you have other things going on as well. How important is it being engaged in clinical trials as a practice and for patients to help push that standard of care forward?
I mean, I think it's critical. I think, there's going to always be the patient population and practice that is kind of skeptical, dubious, doesn't want to do quote unquote experimental work, even if it's under the auspices of a trial. But for our practice, it's a absolute, it's paramount importance because we do believe it's not a one size fits all model. So I'm not incentivized to push someone towards a trial or not. For me, the trials allow us just to offer one more option. And a lot of these discs are already available. It's not truly experimental. They've been around for 10 years in Canada or Australia or parts of Europe, or they're already here. They're just different level indications instead of 1, but 2-level indication. So it's not experimental, but it does give us as a practice an opportunity to in our armamentarium, that much more to give to the patient as an option.
I think that's so helpful for patients to hear, though, right? Is you're not coming into the situation of an experimental. A lot of these, like you said, we've had one level data for a long, long time, right? And now we're just getting 2-level data, so it will get covered by insurance, right? That's half the reason that it's happening.
Absolutely correct.
And it's not this function of, I'm getting this thing that's untested. It's like, no, it's been happening for a long, long time. We just need the reimbursement to be there so we can more broadly offer.
And the reimbursement, sadly, is a whole other landscape that is slow to catch up and often pushing patients towards antiquated technologies like fusions or even worse. I mean, it's really, or denying care altogether, which is probably another podcast talk, because I'm as a healthcare economist background, I'm very, very frustrated by payers that are for profit that, I'm not sure always have the patient's, best interests at heart.
Well, and we talk a lot about how, it's more expensive to get, or a lot of times a disc isn't covered by insurance. And so that option isn't even available to you, even though for a surgeon, you technically have to be more precise and it can be a harder surgery than a fusion. And you're oftentimes paid less for it. And how upside down just the whole world is.
Yeah.
And then that really, it impacts care for patients. That's truly impacting care.
I've never understood it. I've never understood, and it's getting better, but I've never understood how fusions reimburse surgeons more and arguably are easier technically to do, because you can do a fusion somewhat incorrectly, and as long as there's a fusion, the patient still feels okay. Artificial discs are much more nuanced, much more granular, require a certain level of experience to do it well. And yet, I always say to payers, when I'm having a fight to try and get artificial discs or TOPS or something approved, I said, there should be clinical and financial equipoise. Everything should be reimbursed the same, and it should be up to the surgeon. There should be no incentive. it should be up to the surgeon and the clinical assessment of what the patient needs. There should never be a financial incentive to pick one technology versus the other.
We just had this conversation. It's probably what you're about to say.
Yeah.
With Siva, which I'm excited for that to come out because he talked about we should be doing condition-based, not procedure-based.
Absolutely.
And that changes that dynamic of what then really is right, because it's hard. Like that is the game that we're playing right now. You still have to survive and feed your family and like do care. But there's all these other aspects that are like on the game board that maybe shouldn't be.
Yeah, it's great. It's a great concept. Condition-based reimbursement. I mean, because certain conditions are harder to treat or easier to treat. That makes sense. I mean, the problem is that there's no one right answer. And so because the approaches can vary so vastly, it's become a procedure-based reimbursement kind of game and landscape with these payers. And it's hard. I don't understand how behind they are. I just don't get it. It doesn't make sense to me why I can get a 3 or 4 level fusion approved, but I can't with arthroplasty. Because frankly, 4 level fusions were not ever in clinical trials and tested, either, right? Yeah. So I don't see the rationale. And if you look at the failure rates of a 4 level fusion, I mean, I'm not sure why that's even reimbursable, why that's approved.
You look at it is the perverse incentives, right? It's just there's this imbalance of what we should be offering versus the care that someone's getting and the long-term outcomes that somebody's getting from these surgeries, right? Yeah. And what I thought's really interesting, I actually want to jump in, if you're okay with it, to talk about, you published a paper about a motion preservation device, right? So TOPS, and the discrepancy in time when it comes to cost effectiveness, and this is just from a cost perspective, right?
Sure.
Versus a motion preservation device versus a fusion. And I think this hits exactly on the topic that we're talking about. So I'd love to talk about it very briefly if you'd be willing to.
Sure. Yeah. I mean, it was very clear from the data that the improvement in symptoms was much more rapid in the TOPS population, the motion preserving population, despite a slightly increased initial cost. What does that mean? It's a ratio, so it was still cost effective. But what we also saw is that over time, the TOPS population maintained cost effectiveness. And if you extrapolate out far enough, the fusions start to become more and more costly because revision rates and complications and problems and increased pain management visits go up and up and up. So there's a clear discrepancy. The science is really interesting because if you think about, well, why is it if both patients are getting these very large decompressions, which I think is the secret sauce in a lot of these surgeries, the neural elements are open, can breathe, can heal. That's why people feel better. Why is there a clear, faster trajectory on the motion preserving population in that cohort? The way I look at it is motion is natural. The spine is not feeling any different, right? The global kinematics are as similar as possible to your normal physiology. So the only thing that's changed is open breathing nerves, healthy nerves. In the fusion population, open breathing, healthy nerves, but you've now created a complete imbalance. Your spine doesn't know, it wants to move, but the fusion hasn't set, it hasn't healed yet. And I believe that, and this is just my theory, but you have opposing forces going on in the spine that wants to move but is fusing. And that's why the patients will feel better, but it takes longer.
And I think it's amazing just hearing about that as well. Incredible data with TOPS and being able to do some of that work. I think that holds true, like what you said, for other motion preservation devices, right? So whether you're doing disc replacement, we've seen a lot with the Modus total joint replacement, and you're having those same things, right? You do especially a posterior approach, so TOPS or Modus, you're doing a big broad decompression in the back, right? So you're opening up and freeing up all those nerves that have had pressure, or you're stenotic, or for whatever reason, right? Arthritis in those areas. And then you provide a motion preservation device, which you're allowing this natural motion. And I think we're going to start to see some more of these studies. You look specifically at cost effectiveness, right? That doesn't also include quality of life and all these other metrics that are extremely important when you look at the detriment from a societal impact, not just from a payer standpoint as well, right?
Yeah,
and I think that's where it gets really, really interesting in what we'll look at down the road.
Yeah.
That's fascinating. It's amazing. And I want to talk a little bit more about what we had brushed on at the start. Some of the work that you've done in actually bringing motion preservation devices to these underserved areas overseas. And I read
extremely controversial topic. Okay, let's do it.
I should say just to some of these underserved areas, right, where they either wouldn't have access to the individuals that are trained enough to do these, or wouldn't have access to the technologies themselves in some of these areas.
So therein lies the issue.
Okay.
So, and I'll be the first one to take fair criticism, but I can explain why and how we're doing what we're doing. So specifically with Solidarity Bridge, it's just an NGO that actually one of my mentors in Boston is the director of, Richard Moser, very famous neurosurgeon, retired to his chagrin, but an amazing man and mentor. And he brought me on, I think my first trip was 2010 or 2011 to Bolivia. And we looked at ways of providing, actually it was also cost effective and sustainable kind of spine instrumentation and general neurosurgery to the population that was riddled with problems around trauma. One of the biggest reasons for healthcare problems is trauma, mostly due to car accidents and bad lighting, driving conditions, road conditions, and just overall, adherence to traffic laws. Trauma is a big problem in the non-industrialized world in general. And so we looked at ways to determine sustainable solutions. And what we came up with was a very complicated model that, the government would have to pitch in this amount, they'd have to get funding from somewhere else, we'd have to rely on donations. And we basically said, okay, this is a very interesting research project to publish, but it didn't solve a problem. So we have the benefit now of time. We've been back multiple times working with the same group, which is the only way to help. Because I can tell you, for anybody interested in going overseas and doing mission work, you feel like it's a drop in the bucket, and the feeling of helplessness is overwhelming. So what we've learned going back now for years is how to create sustainability has to happen actually from within. We can't rely on donations. I'll explain that. And two, the surgical tourism concept is very dangerous. The surgeons like to go and feel good about themselves, help 1, 2, 3, 10 people. But we often are our own worst nightmare because we can leave a population of doctors and surgeons there to deal with what we've done that doesn't always go well. And if there's a complication, they don't have the technology to revise it. They don't know what to do. So while we still do some of that, we only do it in collaboration with the surgeons there, their patients, their plans, and we help facilitate. And almost the entirety of our projects and our missions are around education. And one of the most exciting things that we did publish about, and we went back, it was mid-2000s, we did the first ever neurosurgery boot camp in South America for all residents and trainees in South America based in Bolivia. We actually had one, it was I think the only South American female neurosurgery resident, like 28 hours on a bus ride to get to us.
Dedication.
Yeah, it was amazing. And we ran a boot camp. And what's a boot camp? Boot camp is the same thing that they do here for every first-year neurosurgical resident, intern. They do it in regions, Northwest, Northeast, and every resident has to go. And the idea is that it's a mixture of didactic lessons and practical with models, learning the standards, the basic kind of little mini procedures in neurosurgery and some of the basic kind of didactic lessons. Why? So that the common denominator is the same for everyone getting started, because there's some variations in the programs. And so we went with some very well-known names in the societies of neurosurgery in the United States and modeled the same thing after the boot camp in Bolivia and had an incredible kind of experience in teaching and showing. And yes, we did some surgeries, but it was all around teaching and this boot camp event. And every trip that has then happened subsequently has been around education, a didactic, a lesson, what we're trying to teach, and then either doing a cadaver lab and then in the months preceding the trip, picking patients that kind of fit that model, that are patients of theirs, of the Bolivians, that we can help with that don't need something urgently, and we can plan around what we're going to be teaching. The last piece of the puzzle was sustainability. How do we use and bring technology so that the teaching is relevant? And so what we were able to do is help them create a spine industry on their own. So they actually will import and have a relationship with India and will find the right instrumentation. And then there's a company that was created in Bolivia that manages like a spine company would here. and they're providing for their own population. What does Solidarity Bridge do? Solidarity Bridge offers social workers that basically assesses ability to pay and costs. And it's on a sliding scale, and people who can pay more will support those who can't, so that there always is the technology available to the population. Because you cannot just rely on the companies who are giving you a bag of donations and hoping it's sufficient. So we needed something that could keep on going when we were gone.
Talk about teach a man to fish.
Yeah, I mean that's
amazing.
It's the only way to make it work.
Yeah.
That the rest, the other models are not sustainable at all.
Well, and it goes to like, you can feel great of, oh, I just did this thing, but like you just created a ripple effect of like how that's going to be able to help more and more people, creating an actual industry. I think that's incredible.
Because we know it's happening when we're not there. We're not. There's not a mission trip every month. Twice a year. We also, it's not even in the spine world. We did pituitary surgery through the nose. How could we do that? We had to give them a scope or two, make sure there is a team there that knew how to fix it and work it. But we also had to train the surgeons how to use it. And we had multiple training sessions of using endoscopic surgery with ENT. Doctor who didn't know anything about it, now is the leading ENT doctor in Bolivia, goes city to city to city with scopes, helping surgeons for access so they can do pituitary surgery through the nose.
Amazing.
They do it on their own now. They don't need us. That to me, not needing us is success.
Mm-hmm.
I think the commitment to the mission work and that objective is amazing, but putting the structure in place so that it is successful is a whole nother picture that you have done that matters so much that we can miss a lot
Still
of
times. Work in progress, but yes, there's always something to be done. We now created a first trauma registry for Bolivia, so we're actually measuring metrics so that we can figure out what's going wrong and what we can do better. But they never had a registry data collection program, and now we have residents that have been sponsored by us and by Solidarity Bridge to go every year with us, and they pass the torch to the next year residents and continue on with those research projects. So there's continuity and ongoing research and ongoing data.
I think it's such a cool concept too, and I actually think it has a lot of parallels to rural care here in the U.S.
Sure.
Right? Is you're providing this context of, and I think we can talk about it in a motion preservation sense, is some of these patients that are in these rural areas, all they have access to is fusion is because the surgeons that are there, all they're trained on is fusion, right? And I think the same concept will kind of start to erupt of, even if these patients travel somewhere to get care and they get it and they go back home, and then now they're primary providers have to now look after them. Well, they have to know how to look after them and know what they're looking for in radiographs and how things are supposed to look, right? Because I think we can see that we've seen that in motion preservation too, is for someone that doesn't know what they're looking at the first time, they can say, oh, this is wrong.
Yeah.
But it's not a lot of the times. It's just, no, maybe you have the wrong tilt or you have the wrong imaging, or that's how it's supposed to be placed. That's how it's supposed to look. It just looks wonky on film, right? Yeah. But I think that there's going to be parallels to that as well, as how do we educate and train and provide the structure so that all, whether it's overseas and underserved areas or in the US and underserved areas, how do we get more patients access to better procedures?
Absolutely.
I think that's so fascinating. And, I want to touch on as well, you've done a lot of that work, but you actually just started as well for UC Davis, where you did some work, a global neurosurgery travel award. So
very violated. You know a lot about me.
I like to say that we're prepared.
Fair
enough. Like to say that we come prepared. But what a cool, and just again, I think it supports your commitment to a lot of this work, that residents can go train and educate and do these things and provide some of this work and be able to work with these populations. But it used to be, it's now the UC Davis, I think it's Dr. Jared Ament Global Neurosurgery Travel Award.
So if he's watching, Kia Chalet is the chairman at UC Davis right now, Dr. Kia Chalet, also one of my old mentors. He insisted. I said, I don't need my name on it. I said, I'm happy just to have 2 residents come with us a year and support that so that there can be engagement and experience and research. And he was quite insistent. I still said no, and he did it anyway. But he is the boss, so what am I supposed to say?
Yeah. Well deserved. I mean,
no, I'm glad that I'm able to do it. And the first 2 residents came last year in November. We have another 2 coming this year, and it was a fantastic, phenomenal experience. And they're still engaged. They're still meeting, with Solidarity Bridge and all of us, every month or so, and making sure that the research continues and the project continues, and we'll pass on to the next group.
Well, it's telling to your just commitment to improve patient care, right? Whether it's here in the US, whether it's overseas, it is incredible to be working on so many things, be so busy, but still say, hey, these are important pieces to aspects of my life and getting it out to patients. I want to bring it back here too to to your guys' group, to NSG. Can you tell us a little bit about, what you got, why what you guys are doing is special, and, the holistic look at care that you guys provide?
Yeah, I think, my partner and I, Dr. Voksher, we really believe in the whole body. It's not just a point in time, a point in care that your surgery is your relationship with your surgeon or your nervous system. We truly believe that we have to do better than just offer a surgery. And whether it be supplements and antioxidants and healthy lifestyle, eating and physical activity, or something like meditation. I mean, at both of our locations, we have what's called the Brain Spa, where we put patients through this virtual reality guided kind of meditative experience. Which, we believe, and we're also obviously collecting data, lowers opiate use and pain reduction. We believe that the supplement that is still not commercialized yet, but have refined and now have a supplement line that we're going to be launching. A lot of that is designed to optimize nervous system healing and patient recovery. So everything that we're doing, it's about balance, and we don't want it to just revolve around the surgery.
I think
it's only, to your point, it's only one point, right?
It's a point in time. It's just it's the nervous system is it's people say the eyes are the windows of the soul, but the brain holds all those memories. But the nervous system kind of is always, people say, why do I have nerve pain after surgery? Because it's almost like muscle memory. It's a reflection of everything that you've been through. Your spine is a reflection of everything you've been through. Right? And your big football player comes in, but the spine looks like a 9-year-old. It's a reflection of what you've been through. And so I think it requires more than just a one-off, hey, here's your surgery. I really believe that a holistic approach to the body, your nervous system, what happens before and after that point where you have to maybe have a surgical intervention is the best way to optimize healing, health, quality of life, and the highest level of function possible while we're here.
Well, I think that brings it full circle too, because you brought up at the start, if you don't need surgical intervention, we don't have to do that, right?
Yeah.
The goal is treatment to get people back to baseline, right? It's not to have surgery. Surgery is an option to get people back to that, but I think what is special here is you're looking at all those options across the continuum.
I've had patients come into the office and I hand them a sample bag of our supplement and put them in the meditation chair. And I said, come back in 3 or 6 months.
Can I go to the meditation?
You may.
Well, that's fantastic. We appreciate you giving us as much time as you have.
Thank you for having me.
Absolutely. It's been fantastic. But for everybody out here that's listening, where can people find you? Not only just practice location, but where can people look you guys up? Where can they schedule appointments? Where do they go?
This is the plug, right? This is where
absolutely right. We want to make sure people can find you.
I mean, we're online. My partner and I, you can look at NSG, Neurosurgery Spine Group, nsg.com or nsg-la.com if you find our website. Instagram, at Dr. Jared Ament, at Dr. Voksher. There's also an NSG Instagram, Neurosurgery and Spine Group, just written out. The website has a lot of information. nsg-la.com is a great place. Instagram's a great place. Reach out. You can call the office. I mean, we're always happy, honestly. We're always happy to talk. If patients just want to chat and they don't want to necessarily travel, we do a lot of Zoom or FaceTime where it's never the same, but it's surprisingly good. People like more than a phone call to see the person that they're talking to, and we all know that from our family interactions. But even with the patient-doctor relationship, it's better than just a phone call. It doesn't supplant the physical exam and the in-person, but it's certainly something. So we're always happy to do a Zoom or a FaceTime or whatever, is easy, and we can try our best to facilitate that. We do people overseas in Europe with time differences. We'll make it work just so you get a sense of what's available, what's potentially an option, what you may or may not need, what's more urgent and what's less urgent, and how to take care of yourself in the interim while we're trying to figure it out.
Well, I think sometimes just that phone call or that Zoom call, like you said, it might not be an in-person meeting, but it's giving credence to some of that. I have anxiety about this, right? Sure. I don't know how to think about it, right? Sure. They just want to hear from a surgeon, here are your options, right? Or here's what you should be concerned about versus what you shouldn't be concerned about. And I think it's just another option that you guys are providing.
Yeah, and that anxiety is often, it's not misplaced. I mean, people have real concerns. There's a lot of information and misinformation out there. And sometimes that initial Zoom phone call or meeting is really important just to kind of set the path, good trajectory, figure out the next steps.
Well, I will say I recommend anybody that hasn't followed you on Instagram or LinkedIn. You share a lot of content there, right?
Great
Both
stuff, yeah.
personally, but educationally for spine patients and for patients who say maybe I'm not ready for this intervention. There's a lot of education on there, and I think both you and your partner, Dr. Brookshire, do a fantastic job.
We try.
Of getting that
Thank
out
you.
there.
If you're reading the forums, also go over to his Instagram.
Exactly
Make sure
right.
you're balancing it out.
Exactly right. Well, thank you so much. We're hoping we get back to West Hills soon. So this is fantastic. Thank you so much for
Thanks
your
for
time.
having us.
Pleasure. Thanks for having me, guys.